from UK, but I will give you today, as I have given already, your colleagues, GI. Next week it will be nephrology doctors. So I have this history. We are medicine workers. Okay. That's all right. So today we will talk first about the peptic ulcer disease. يلا يا جماعة. So our objective in this slide, in this lecture, this seminar, in this lecture, will be the definition, the comparisons. So you should be able to define, compare, know the etiology, the causes, the clinical presentation, how to manage, and if there is any emergency scenarios by the end of this lecture. Okay. So basically, what is peptic ulcer disease? Okay. Peptic ulcer disease refers to erosions in the mucosal lining of the GI tract, circumcised ulceration in the lining that leads to exposed areas to acid and epsom, and we will show you in the next couple of slides how things goes and how ulcers develop after being exposed to acid and epsom and H. pylori as well. Gastric ulcers is the same, but the difference, whenever you see a gastric ulcer, take a biopsy because there is a chance to be a malignant, higher chances around 20%. Duodenal ulcer most of the time in the first portion, and it's 4 times commoner than the gastric ulcers. Okay. So this is the normal anatomy, the esophagus and the stomach. All of us, we know the esophagus, the cardia, the fundus, the body, the antrum, the pylorus, and the duodenum. That's important. The most common sites for gastric ulcers are on the lesser curvatures. This one, the lesser curvature, you know by, and the anatomy. This is the lesser curvature. And the most common duodenal is the first portion. We have 4 portions, as we know. The length of the duodenum ranges between 20 to 25 centimeters. Okay, next. Okay. That's an introduction, how things go. So we got the cells, the membranes, the cells contains phospholipids. And we know there is an enzyme called phospholipase A2. That's the precursor enzyme for the arachidonic acid. And the arachidonic acid will be the precursor and will be the substance that will be acted upon with the COX-1 and the COX-2, cyclooxygenase 1 and 2. Cyclooxygenase 1, as you see, is a housekeeping enzyme. It produces enzymes and substances that protect the stomach, causes vasodilation in the kidneys, and thromboxane that causes aggregation and improved platelet function, and as well protecting the endothelium. So it's a housekeeping. Like the norepinephrine is the housekeeping stress hormone, or the vasopressors is the same. Okay, so whenever you see housekeeping, this is most of the time it's the running one, usually. COX-2 is found for inflammation as a response for any injury, either external, internal, endogenous, and exogenous injuries by bacteria or mechanical traumas. Macrophages, when there is a recruitment of the inflammatory response system by the innate immunity, the humoral and mixed adaptive, and eventually will be the response either healing, complete healing, or towards scarring by fibroblasts. As you see, macrophages, leukocytes, endothelium, and fibroblasts. COX-1, as we said, thromboxane A2, prostaglandin I2, prostaglandin E2, or that's the one that causes protection for the lining, I2, and causes vasodilation, I2 as well as protect the endothelium. Prostaglandin I2 and E2 as well, they are responsible for inflammation, mitogenesis, angiogenesis, and bone formation as well. Next, please. We'll talk about that. Why is it important? It's important in the peptic ulcer because the Old Testament says no acid, no ulcer. Okay, but nowadays it's no Helicobacter pylori, no ulcer. We'll go through that. So the acid, how you can see as well the parasympathetic system, the vagus nerve, affect multiple cells within the antrum and the body and the fundi of the stomach. So the D cells and the parietal cells, they are found in the fundus. The parietal cells, as we know, they are the cells responsible for HCl or hydrochloride or the acid to be secreted. خليكم بس حديث الباب إذا سمحتم من الصف الأخير. شكرا. Okay. There is a receptors for histamine, and as you know, part of the treatment of the peptic ulcer is H2 blockers, because the histamine is the main or one of the main mechanisms in secreting the acid. And acid, as we said, is quite important in weakening the defense mechanism of the cells, in addition to the pepsine, which is an enzyme that's secreted by often by the pancreas, and as well it can be pancreas and other cells within the stomach, okay, that will help digestion of the proteins. The B cells, they will act as a negative feedback mechanism on the parietal cells in case there is excessive acid secretion. The vagus nerve innervates the stomach, as we all know, okay? And with the acetylcholine, which has a positive feedback, stimulatory effect in the parietal to secrete acid, and it has a negative feedback, and the D cells will secrete somatostatin that will suppress the parietal. In the antrum, the vagus has another role. The G cell, the gastrin cell, that has as well a positive feedback or a stimulatory effect on the gastrin. Gastrin acts on the parietal to secrete acid. These cell acts as the negative feedback to balance between excessive secretion and decreased secretion as a response to the food as well. This is quite important. If there's a fatty food, high protein food, usually the acid is higher. So that's why in the fast food, junk food, sometimes when you eat it, especially at night, you feel that there is some reflux, acid reflux as well, because of increased secretion. Okay, this slide is quite important in the mechanism, and that shows you that the vagus and the parasympathetic or the neurohormonal system is responsible as well for ulcers. In the old days, they used to treat the peptic ulcer disease with one of these vagotomy, is to get rid of the vagus nerve. Nowadays, it's just some tablets. So when they introduced the H2 blockers, the antihistamine, it was a revolutionary treatment in the treatment of acid-base, the peptic acid ulcer, because before that it was a surgical treatment. Next, please. Again, about the parietal cell, how the histamine interact with the histamine, or the gastrin, how the somatostatin and the D cell there on the suppression. Sorry. So yeah, look at the parietal cell, how the acetylcholine acts on the H plus ATPase intracellularly. So the acetylcholine is a neurotransmitter. There will be a secondary messenger within the cell, intracytoplasmic, then intranuclear, that will act and such it in the H plus K ATPase co-transporter receptor that's responsible for activation of the parietal cell and excretion of the H plus in addition to chloride, which means acid. The BBI, the proton pump inhibitors, they act on this receptor. Okay, next. Again, another slide to show now the role of the H. pylori. H. pylori, as you know, is a helical spirochetal bacteria that invades the mucous membranes and does not invade the cell. Okay, does not invade the cell. It weakens the mucus. The mucous membrane is is the first line, defense line mechanism to protect our mucosal lining into the GI tract. Okay, so once we get an acute infection, there will be breakage in the mucus. They will break the urea toward the ammonia, because they have urease enzyme. They have the urease enzyme, and memorize that, because it will be one of these enzymes that we can measure or we can test for in the urea breath test, how the patient excessively can produce urea. Okay? The Helicobacter can go into acute infection and can go toward chronic infection, either asymptomatic or symptomatic. Sometimes that depends when you do an endoscopy and take a biopsy from the intron. Most of the time we take biopsies from the intron if there is nothing, and we do nowadays they do urea breath test. I will show you in a couple of slides. And if it's positive, test and treat approach. We do it. We treat it if we find it, even if it's symptomatic, asymptomatic. Probably before a couple of years, they used to send the culture and histology to see if there is a gastritis, chronic active. So you get the pathology report, chronic active gastritis or chronic asymptomatic gastritis or chronic gastritis that not affecting. It depends. So before it depends on the histology. If it's chronic gastritis not causing symptoms, asymptomatic, do not treat. So it wasn't like that. Test and treat. Still there is this approach, you can do it. You can wait if it's asymptomatic, why to treat, why to bother yourself. Or nowadays it's test and treat. If you find it, treat it. And some of them will tell you in the functional dyspepsia, when we find the serology as well, the antibody positive for H. pylori, we treat and we wait and we retest for it. Okay? Endothelial cysts, we got the stasis, ischemia, and then erosions first, then ulcers, then healing, either spontaneous or therapeutic, or the BBI. The epithelial effect, the prostaglandin, once it's depleted, because the prostaglandin E2 suppresses the secretion of the chloride and increases the mucin secretion and the bicarb within the mucus layer, which is protected. All of these will be lost by the depletion of the prostaglandin for those who are taking NSAIDs. So NSAIDs, it's great risk factors for ulcers. Next, please. Okay. Causes of ulcer not caused by H. pylori, non-H. pylori, non-acid, NSAID ulcer. Infections like cytomegalovirus, in those who have underwent transplant, we found it in immune suppressed more than immune competent. Immune suppressed special solid organ transplant who are an immune suppressant like tacrolimus, cyclosporin, and other immune suppressant. HSV herpes simplex virus, never seen before, but it can be Helicobacter pylori, another Helicobacter, that's not the H. pylori, the known one. Drugs, bisphosphonate, osteoporosis drugs, those bisphosphonates like anandronate taken once weekly. They do ulcers and they do reflux esophagitis, severe reflux esophagitis. That's why the caution when you prescribe a bisphosphonate for any patients, they should take it first thing in the morning, before, not first thing in the morning. First thing they take BBI, then they take it, and they should be upstanding and sitting, not in supine, for at least 45 minutes because it will cause reflux esophagitis. That's quite important. Chemotherapies, clopidogrel, antiplatelets, that's also the case. Crack cocaine, all of these causes ischemia because the crack and the cocaine causes ischemia, can cause ulcers, and as well it can cause some guys, young chap might come with MI or vasospasm, metal angines in the heart because of the cocaine and the sniffing cocaine. Glucocorticoids, especially when it's anti-NSAIDs, because the steroid, they will suppress the phospholipase A2 from the top of the hierarchy and eventually will suppress all the protective effect of the prostaglandins. Okay? MMF, mycophenolate, mofetil, potassium chloride, all of these oral, this will cause that. Myeloproliferative disorders, basophilia, because of the secretion of the histamine. If you put a lot of basophils in there. Duodenal obstruction and the pancreas as well, because there will be reflux of the bile and will be retention of the acid. So eventually the transient time will be this. So more the acid will stay more within the stomach and the duodenum, and this will cause further damage and direct damage. So and regarding the NSAID, I might just come back. The NSAIDs have a direct and indirect effect on the epithelium. The indirect effect we mentioned, it suppresses the prostaglandin. Who knows the direct? About how NSAID will do direct injury to the epithelium.
يكون acidic aspirin.
Might be. What does that mean? يعني كلمة شوية كثير
express defense mechanism.
This is the indirect. This is the indirect. The direct. Direct. There is a direct. So you have to memorize that. Two. Direct. زميلكم كان قريب almost near that.
جسم بفرز اسيد عشان يعمل
No, you mentioned about the negative charge. You mentioned about and disrupt the negative charge. Disrupt the negative charge because the carboxylase within it, okay, disrupt the negative charge and disruption of the membrane, disruption of the mucous membrane, and this will allow to cause some erosion and not some erosion, opening within the mucous membrane. Once you get open, the acid and the pepsin will go and they will attack the membrane and they will weaken. You will see some slide, nice slide about that. Okay, next. Good thought. And just come back, other diseases like ischemia, radiation, eosinophilic infiltration of the GI tract causes ulcers, sarcoidosis, Crohn's, maybe next week, Crohn's and ulcerative, not next week, after 2 weeks. We'll talk about the Crohn's and the ulcerative and the diabetic respiratory state, and as well something called Zerlinger-Nielsen syndrome, which is a gastric tumor. Okay, it's tumor within the G cells, excessive secretion of G cells, this will cause hyper acidity and excessive chloride, HCl secretion and more acid, and eventually will cause that's also classified one of the causes of malabsorption because it causes diarrhea as well. Okay, next. So, how to test for the H. pylori? So, previously, no acid, no ulcer, nowadays, no HB, no Helicobacter pylori, no ulcer. Okay, so we have invasive and non-invasive. Invasive by the endoscopy, as we said, when we do the endoscopy, we take an antral biopsy pipes with the forceps, put it within the kit. Within 2 minutes, 3 minutes, it will change from the yellow to the red, which means it's a positive urease. And if you found it, treat it, even if it's asymptomatic. Even if you have done the endoscopy for something different, looking for iron deficiency, anemia causes or anything, or just screening, okay, you have to treat it. So rapid urase is quite sensitive and specific. Specificity is very high, around 100%. Sensitivity 80-90%. Cheap, though it's invasive, but it's cheap. False negative with recent DBI antibiotic and bismuth compound. So you will give patients precautions and advices for those who are coming to endoscopy looking for H. pylori and ulcer to stop any antibiotics, BBI at least. How many days at least? Yes, to stop. 24 or more than that?
Sorry.
At least 3 days. Why is that? Why 3 days? Yes. Why at least 3 days? And some tests different. For example, if you want to do impedance test or a pH manometry for reflux disease, you want them to stop it for a week. Okay? But in H. pylori, they might stop it a week or 3 days at least. يعني ممكن تحكي له week عندي. Why 3 days at least?
عشان يروح مفعول.
هو بيعمل سبريشن
مفعول. You mean the effect of the
يعني
نرجع يطلع ريسبتور جديده كانه
cell another
أيوة.
because yes, so because if you remember from internal histology, the GI tract they renew every 72 hours. So by now the receptor is occupied with the BBI. Just to wait for another epithelium, new epithelium, okay, in order to see what's going on. Okay, that's fine. That's good. Excellent. Histology. زمان كنا نعملها. Nowadays, this with the rapid urase, they take the biopsy, send it to the pathology, look for H. pylori, they culture it, and they see if there is gastritis as well. So they culture and cytology. They send it to the culture and cytology under the microscope. They see if there is changes, those with gastritis, acute, chronic, active, moderate, mild, they give you this classification. Culture, time consuming, expensive, it takes time. We don't do it, often do it. Non-invasive serology, as we said, we test for the IgE and the IgA and the IgG. IgA is a recent infection, and that you have to memorize that it might stay up to 20 months sometimes. And ممكن واحد infected in the last 2 years, this IgA might last up 20 months. IgG is the past infection. And if you find IgA negative IgG, this is past infection. IgA, some of them when they say, it depends on the titer as well. If the titer is high, it's positive, they treat. Some of them, even the IgA is positive and he is asymptomatic, wait and see. So different approaches, but nowadays most of them they say just treat. If you find it, rapid urease or serology, treat, test and treat. Okay. Urea breath test, that's good one as well. Urea, we give them a radio-labeled carbohydrate, as you see C14 test, carbohydrate, and they ask him to drink it, and the urease within the helicobacter will break the urea, and on the breath, you detect it in the breath, there is a limit, above the limit, below the limit, it's detectable, not detectable. That's good. We use it as a follow-up test usually, often. So after treatment, manual endoscopy, if you have this facility and the fancy to do the urea breath test, it's done. Okay. So غالبا done after 8 weeks, because you ask them when you treat, as you know, as we tell you, the peptic ulcer disease, often the triple therapy or the quadruple for 10 to 14 days, then they will continue the BBI for at least for 8 weeks, and I2. Then after that, we stop that, then we test whether the urease is as a follow-up test, if it's still there or not, okay? To know we have eradicated or not. Stool antigen, inexpensive, convenient, that's good, but it's not always there, to be honest. So we can do it as well. Next. Drugs that you use in peptic ulcer treatment, acid suppressing drugs, antacid, all of us will know that, H2 blockers, as well with different drugs. Ranitidine has been withdrawn from the market in the last 3 years because of some teratogenic and effects, especially by the endo even. And with the revolutionary medicine in the last 30 years, when they first presented the BBI, now is number one treatment because it suppresses more than 90% of the acid. Okay, H2 blockers 60 to 70% acid suppression. So we go to our BBI more nowadays. We have the omeprazole, lansoprazole, lebrozole, and lansoprazole, esomeprazole. Probably the most common one is the esomeprazole, the latest which is in the market in the last 10 years has been introduced, and after that no new PPIs has been introduced. كلهم عبارة عن isomers, so just changes in the side chain of the molecule. Just to memorize this thing, that when you treat a patient, especially with ischemic heart disease or stroke, and your colleague wants to give him Plavix, just to remember the interaction between the BBI and the Plavix. The interaction often between the omeprazole and the nexium is the higher, and the Plavix, which suppresses the action of the Plavix. So patients who take omeprazole or esomeprazole with Plavix, they will suppress the effect on the Plavix, and they are liable more for strokes or ischemic heart disease, which means the dose of the Plavix will be subtherapeutic. The least, and usually we advise, is the lebrozole. The lebrozole is the least interaction with the Plavix. Okay, memorize that. The least interaction with the Plavix, so we would like to prescribe or pantoprazole. Both these two, they have the least interaction, being the lebrozole the least one. Okay, so whatever you have seen that, you can advise for that. Okay, next please. And we put the mucosal protective agents, sucralfate, prostaglandin, misoprostol, bismuth containing compound, which as well used in the treatment of that priority whenever we go for quadruple therapy rather than triple therapy. Next.
دكتور بالبريجننسي نعطي الرابي صح؟ الرابي برازول بالبريجننت women.
Safety, to be honest, BBI in general, some of them they categorize them as they wouldn't like to prescribe it, some of them, but if they have peptic ulcer and, for example, have gastroesophageal reflux and the pregnant lady, she's stable on that, continue on that. There's not a lot of studies about the safety of the drug in the pregnancy and which trimester. Some of them, if you want to initiate an H2 blocker, famotidine, okay? If you want to initiate. Some of them, yeah, but if the patient is already in a BBI and she goes to pregnant, continue. Most of the literature, and not just for the BBI, asthma, wherever drugs, chronic drugs or chronic conditions, that your patient is stable on, and the safety, the literature about the safety in the pregnancy is equivocal between category B and C. B is safe, C there is no studies, and the human studies just in the animals. Often keep on that, continue that with the caution. Don't worry about that, because it's rather better to keep your patient under control rather than to remove the drug and she will get in trouble. For example, getting a lot of reflux symptoms, or her acid or ulcer relapses, or her asthma not to be so, or her asthma as well get difficult control or relapse. So do no harm. The guide associated do no harm in the treatment. If the patient is more stable, keep on that. We'll keep an eye. I will go with the literature. If there is a strong evidence about teratogenicity, no, you have to switch. If there is no strong, you can with caution discuss it with your patient, give the benefit versus risk, and talk and take things from there. Okay, next. Okay. So recommendation for treatment for NSAID-related mucosal injury. So NSAID sometimes causes erosions, gastritis, and eventually it might cause ulcers. So we have a grade, gastritis, erosions, ulcers. So it's spectrum. So مش كلهم لازم يكون ulcers, okay? So in the active ulcer, NSAID should be discontinued and BBI or HT blockers should be prescribed. NSAID can be continued with the BBI if given that, in endoscopy and we find it's mild erosions to gastritis rather than ulcers. Okay, prophylactic, we can give in those who have a history of peptic ulcer due to NSAID. You can give misoprostol BBI, selective COX inhibitors like celecoxib, COX-2, celecoxib for example, and rilacoxib. These are safe and gentle in the stomach and the tummy, and which be given. Antibiotic, if there is an ulcer, eradication treatment is the best. Okay, next. Guide to NSAID therapy, that's good, right? So you have to remember there is no cardiovascular risk, no aspirin, and the risk for GI bleed, he doesn't have any history of GI bleed or whatever, we can give the traditional NSAID. If there is a higher risk of bleeding, previous bleeding, and steroid, and other medication that might cause ulcer, you give them the traditional, either the COX-2, celecoxib, or traditional NSAID plus PPI or misoprostol plus protection. And often we try to avoid the NSAID as much as we can unless we need it, okay? If there is a cardiovascular risk and there is an aspirin or Peptic, for example, traditional NSAID can be used for those with back pain, rheumatology, but sometimes you need NSAID, like ibuprofen, this stuff. This pain cannot be relieved, anti-inflammatory, you need it. So we cover them with BBI and gastroprotection. And those with NSAID GI risk plus cardiovascular risk, gastroprotection must be added if provisional NSAID is prescribed, consider NSAID. So this slide shows us that not all patients you commence them on aspirin should be on lansoprazole or BBI, and we know by now there is a lot of malpractice in the community. عياته حدا بيحطوا على aspirin give him BBI. This is never good. If they don't have any, if they are at lower risk of lower GI bleeding, why? ليش تخاف? You ask him. Not smoker, مش coffee drinker, مش steroid, مش. Okay, that's fine. Continue like that. ما عندك history. حتى إذا أنك شايف إذا عنده, you add protection during that period. مش ضروري يضل عليه مدى الحياة. Okay? Next. That's tips for the general practice you see it a lot if you do the daily practice. Okay, nuanced dyspepsia. Okay, so nuanced dyspepsia, we look for if the patient is above 40 and have alarming symptoms. Alarming symptoms like what? Dysphagia.
Recurrent infection and bleeding. Okay.
GI bleeding, one of them, if there is associated GI bleeding.
Vomiting.
What do you mean? Acid base, reflux, and hard, that's fine. At night symptoms, okay? Dysphagia, if associated with dysphagia. Weight loss, alright. Okay, that's good. Weight loss, dysphagia.
Hoarseness of voice.
Night symptoms. Hoarseness of voice, reflux. يعني بس progressive stage or adenocarcinoma. All of these are weight loss, as the colleague said, or associated with GI, or previous or family history of gastric cancers or GI tract cancers, خاف من الموضوع. Okay, and he is above 40, alarming symptoms. If there is positive, refer him to the GI, ما تفكر بالموضوع, refer him to the gastroenterologist. If you get alarming, ما في alarming symptoms. Okay, less than 40, ما عنده alarming symptoms. We do an invasive factor testing, the blood, the serology. Positive, treat for that. 4 weeks after therapy, confirm eradication with the urea breath test, okay? Symptoms remain or care, we send him to the gastroenterologist, because gastroenterologist, غالبا راح يعمل endoscopy, يقول عنده غالبا was commence him on second and third line, some of them. I will tell you about that. Non-invasive testing negative, نعطيهم empirical, either H2 or BBI. وننزل أسرع BBI, we give them BBI for 6 weeks, أو أنت حاول تحوله من البداية، أو you give him this trial, BBI for 6 weeks by 2, Ranzolrazole by 2 for 6 weeks trial. If he is okay, he's okay, that's fine. غالبا يعني transient وعدد. If he's not okay, send him to the gastroenterologist for endoscopy. Okay, next. تمام. The defects in enterohepatic circulation of bile acid. This as well, they are quite important in the peptic ulcer disease as well, because the bile acid retention of bile acid might cause increases the injury of the epithelium, especially the duodenum, where the bile acid is secreted in the second part of the duodenum. Next, please. So, peptic ulcer disease, the pathogenesis, the protective factors versus the hostile factors. The hostile factors, the H. pylori, gastric acid, pepsins, NSAIDs, and we look at the protective. Whenever we have the protection is more, so we are fine. Okay, the bicarbonate, the mucus production, prostaglandins, the blood flow, there is no schema in there, so they are protected with healthy mucosa, and the B1, as you say, the hostile, so it's a balance between the factors. Okay, it's a balance between the factors. Next, please. So, as we said, we got the peptic ulcer disease, normal, increase, normal, there is anything, the AB, increase hyperacidity and pepsin and NSAID, C, weak defense, next, please, Helicobacter syndrome. Next. That's the one I was talking about. So, A, your defense is okay. B, you get the hyperacidity, pepsin and NSAID, so you get the attacks, very strong vessels, so that mucosal line cannot handle these attacks. Okay. C, we have weak defense. We have already weak defense. Okay. H. pylori are weakening the defense, stress, drugs, and smoking. Okay. Nice slide. Peptic ulcer disease. By now, the same vagal activity, H. pylori, NSAIDs, all of these things they will start. First of all, gastritis, inflammation of the lining, erosions, then ulcers, and they will be affected. And the ulcers, if it's deep enough, they will involve the vessel and you will have a bleeding ulcer. Okay? So the most common cause of RGI bleeding would be the peptic ulcer disease by now, okay? As we know. This is the erosive gastritis, so just the mucosal and little bit of the submucosal, and the ulcer there will be involvement in the muscularis and the submucosal layer, the muscularis and mucosal as well. Next. Again, the same with the microscopic view for that, and you see the mucosa, submucosa, and the muscularis external involved in the ulcer. Next. Okay. Alarming symptoms, as we said, the age above 40, unintentional weight loss, persistent vomiting, dysphagia, progressive, unexplained anemia. So, yes, excellent. One of these causes, if you look for iron deficiency anemia, especially in pediatric age, not that it's common, especially in pediatric age, you have investigated thoroughly and you did not find any cause for iron deficiency anemia, nothing explained, look for H. pylori. Look for H. pylori, because it's unexplained H. pylori is symptomatic iron deficiency anemia. Hematemesis, vulnerable abdominal mass or lymphadenopathy, you start thinking about malignancy, family history of upper GI tract cancers, previous gastric surgeries, because at the site of the anastomosis, ulcers are more likely to develop there, or sometimes cancers. And jaundice, whenever there is jaundice, this is an alarming feature, or or tumor, or something obstructing the elevator in the second part of the duodenum. Next, duodenal ulcers and gastric ulcers. Duodenal ulcers are 4 times common than the gastric ulcers. Most common middle age, 30, 50, male to male, female ratio, male أكثر عندهم للأمانة. Might be into genetics, to stress, might be a lot of things, yes, that's true. There is a lot of confounders that if you want to study. Genetic 3 times more common in first degree relatives. There is a genetics as well. In the duodenum. More common with the blood group O. Who knows why that? Just out of interest. Who knows why? Duodenal ulcers, there are more, or patients with the blood group O, they are more likely, let's say, to develop duodenal ulcers, peptic ulcer disease. Any thoughts?
لها علاقة بالبلد ترانسفيوجن يعني؟
Transfusional.
بلد ترانسفيوجن الواحد.
واحد عنده blood group O, he is more likely to develop duodenal. أشبه لنا
So no antigen هو.
يعني which antigens you are talking about? Because they have AB here. أنت قريب بس مش AB. That's good. مشان أسهلها عليكم. The ABO system depends on what? Which proteins? Its ABO system is transcripted by chromosome 9, genes in chromosome 9. لقينا complex carbohydrates. بناء عليها we said this patient is A, B, or O. If O is yes, يعني A, there is antibody against B, will be antibody against A. O, we have 2 antibodies, okay? أو ما عندنا الانتيجين, okay? والعكس صحيح, okay? So A, we have antibody against B, and then antigen A, and antibody against B. B, we have antigen B and antibody against A. A, B, we have 2 antigens, we have no antibodies, or we have antibodies. That's not the question. So complex carbohydrate type 1 is chromosome 9. There is another complex carbohydrate type 2, which is called Lewis antigen Lewis antigen blood system. So the ABO system, that's some Lewis B antigen. Never heard about that. So it's not just the only classification system ABO for the blood, okay, or Lewis for our testing. It's not the only one. We have something called Lewis antigen. So it's a Lewis antigen B that's found in O, blood group O or more. They are exposed and that's why they react on them more. That's why. Very important. Associated with increased serum carcinogen, H. pylori infections, almost 95%. Whenever you see a duodenal ulcer, there is H. pylori there. خلاص ما تشوفوا duodenal ulcer, treat H. pylori directly. Don't think about it twice. Smoking is twice common as well in the duodenum. More gastric ulcer, more common in late ages, middle ages, increases with age, male 2 to 1, more common with blood group A. Use of NSAIDs associated with 3 to 4 folds. Down NSAID they affect more the gastric because they have the lining, the surface area is more, and the direct effect, the direct injury acts more on the gastric. So that's why I asked about direct effect, direct injury of NSAID. That increased risk of gastric ulcer. This related to H. pylori about 70 to 80%. So much damage we treat unless we have a positive rapid urase in the outcome. Okay, unlike the duodenal treating directly, 10 to 20% of the ulcer, they have concomitant duodenal ulcers, and we have to take a biopsy wherever there is a gastric ulcer. Take a biopsy because there is a risk of 20% of malignancy. It's good to do that, but malignancy عالية. ممكن أقل. Reachable 20%, that's increased risk of gastric ulcers. Okay, for that, in gastric cancers. Again, in incidence, more common, less common. Anatomy, first part of the duodenum anterior wall. This curvature of the stomach, the gastric. Duration can be acute and chronic. هناك دائما غالبا gastric أكثر chronic because they have time, because of the large service, because of the blood supply. So often they present lately and chronically rather than acutely because the supply service area of the duodenum is this, so most of the time, and the duodenum often they come in the anterior wall, they irradiate, they cause perforation, penetration, then perforation. So penetration, when it comes in the posterior wall and it hits the pancreas, the pain, the gastric pain will radiate to the back. Okay, this is called penetration. يعني بعدها مش عامل perforation. Still, it's just affecting the. It's not perforating the serosa. So we have intact serosa and almost muscular there. So mucosa, muscularis and serosa and the serous layer. So the serous layer is intact. If it's perforated, so there is no intact serous layer. And often this patient they present acutely with air under the diaphragm and severe pain that's from uterine sometimes, okay? And malignancy, very rare malignancies, and as we said, could be gastric, there is an increased risk of ulcers, so wherever there is gastric ulcer, take a biopsy from that ulcer. Okay, next. Causes, infection by bacteria, Helicobacter, 80-95% as we said, that's weaken the immune system, stress, emotional trauma, surgical excess, acid protection, and drugs. We have mentioned that. Next, please. Risk factors. We mentioned that. H. pylori in the top. No H. pylori, no ulcer. NSAID, steroid, smoking, alcohol, genetic, Zollinger-Ellison, gastrointestinal secreting syndrome, this blood group or hyperparathyroidism. And why hyperparathyroidism? Next, please. Why hyperparathyroidism?
Excess secretion
of
gastric.
Yes, calcium. Calcium, because there is receptors called rhinodine that's found as well in the stomach, found in the muscles. This rhinodine, this is an intracellular receptor that will activate the ATPase and effectively will activate the HCl reaction.
Doctor, any drug contain calcium also risk for the ulcer?
Sorry?
Any drug contain calcium also risk for ulcer?
Not any drugs. So calcium supplements and vitamin D, they increase the risk, but not always, to be honest. Unless they are associated with other risk factors, smoking, NSAIDs, corticosteroid. So calcium on its own wouldn't do that. They need another risk factor. So حتى hyperparathyroidism, and rarely they present with an ulcer isolated, hyperparathyroidism TG ulcer isolated. Unless they're usually associated with other risk factors, so the immune system should be weakened. Most specialists, they increase the excretion of HCl, yes, that's true, but you have the other risk factor, you have to, زي ما حكينا hospitalized is protected, you have to embed that strongly. Okay, next, okay, yes, next, so this is the testimonial we're talking about. Most common infection, 20%, 10%, no, 10% and then 4% peptic ulcer disease, positive around 100%. H. pylori related disorders, chronic gastritis 90% من الحالات, peptic ulcer disease 95 to 100%, gastric carcinomas, interesting, 70%. How is that? Against gastric lymphomas. So after thinking, especially the lymphoma, what happens? What do they call it? The mouth. Not the mouth.
Mucosa associated.
Mucosa associated lymphoid tissue infiltration. So myeloma, because of the chronic infection, there will be invasion and infiltration of the lymphocyte and the recruitment of a lot of cells. And through these cells they can mutate and they can now stop obeying the body. When the cells stop obeying the body, this is the cancer. Okay, stop obeying the body. This usually not they are precursors, they are cancers. But they are localized. They are indolent. We're watching indolent, slowly, gradual onset, insidious, بطيئة في النمو, but we have to take it seriously. And by the way, if you treat H. pylori, mouth will be treated. But if they develop into lymphoma, so like a mutation, this time you need chemotherapy. Okay? Reflux esophagitis and mental dyspepsia. Next, please. H. pylori, as we said, does not invade the mucus, break down the urea into ammonia, and break down the mucosal defense. Next. That's the shape of it. H. pylori, urea breath test, carbon label breath test, C14. They add the radio label at the carbon atom at the site of 14, number 14, stool antigen serology endoscopy box next. This is the ureapeptis that I was talking about. The yellow is negative, the red is positive. لما بيعملوا biopsy في endoscopy, the endoscopists they give the forceps to the nerves, and the nerves go quickly on that. And if it's positive, this is positive treated. Okay, next. Differential diagnosis of gastric pain, as we know, the gastric pain is the presentation, sometimes on right upper quadrant pain. Biliary colic acute cholecystitis, pancreatitis, perforated viscous due to penetration and perforation of the ulcer, acute appendicitis malignancy, medically gastroesophageal reflux, MI and BE sometimes might be differential because MI, especially inferior MI, can present with the gastric pain, BE and pneumonia if it's basal pneumonias as well. Next. Symptoms of peptic ulcer disease can range from asymptomatic to severe. So, occluded gastric pain, nausea, oral flatulence, bloating, distension, heart pain, and pain radiating to the back. And which ulcer is aggravated by eating? Gastric or duodenal?
Gastric.
Gastric, excellent. And the duodenal often relief because the alkaline will relieve that. Okay, that's good. Next. Alarming signs of epigastric pain, chronic GI bleeding, iron deficiency anemia, intentional weight loss, progressive dysphagia, short dysphagia should be progressive, persistent vomiting, epigastric mass of fear in the exam, and patients above 55 unexplained and persistent on the onset of dyspepsia, this should alarm, is the alarm, and mild symptoms as well, any mild symptoms, this is an alarm.
Suggesting cancers. Suggests malignancy.
Alarming features, يعني might be malignancy, you're right, that's يعني might be not, might be يكون reflex on ضعيف. مو بس yeah, you're right. And should be bear in mind. Once you see a patient with alarming symptoms, ما تتركوا الأمور يعني هيك. You should be worried and concerned. Manifestation of peptic ulcer disease, episodes of remission and exacerbation. So patients sometimes they might have remission, they might have exacerbation. باكل اللي بتعمل مشاكل، بقعد فترة كويس وهكذا. Sometimes pain due to duodenal ulcers is often relieved by eating or antacid GI bleeding and possible hemorrhages in 20 to 25%. So يعني GI bleeding يعني 20% of them they will bleed, not that much. Perforation of the ulcer is associated with significant mortality. إذا وصلت الperforation معناها آخر جراحين ولسه يعني there is and obstruction often if it comes in the antrum sometimes it comes in, so though it's common in this temperature, but إذا أجت على البايلورس والantrum ulcer it heals with the stricture, with fibrosis, causes strictures and causes obstruction. Okay, next. Peptic ulcer disease endoscopy with diagnosis, barium meal, we used to do that, but nowadays not now. Biopsies, H. pylori, we are already said about that. Next, please. The complications, the bleeding, chronic acute cancer, fibrosis, strictures, pyloric stenosis, perforation, peritonitis, emergency area of the diaphragm, gastric carcinomas, and أكثر ما في الجدول carcinomas. Next. Non-pharmacological treatment, that's good. That's the thing that you have to advise your patients always. Avoid spicy food, xanthine containing beverages. Why? Avoid alcohol, smoking. All of these, they weaken the protective mechanism. They weaken the protective mechanism. Avoid heavy meals, because heavy meals is related with heavy acid secretion. Okay? Encourage small, frequent, low-calorie intake, because low-calorie meal and high-calorie protein and fat often needs more pancreatic enzymes, pepsins, acids, and this stuff to be digested and absorbed. Avoid drugs. We have mentioned that. Next, please. Peptic ulcer disease, wherever the H. pylori is there, we have two lines, triple therapy and quadruple therapy. Triple therapy, the number one first line is proton pump inhibitor, clarithromycin and amoxicillin, and you can see I put something between the brackets, wherever the clarithromycin, in areas where the clarithromycin resistance is 50%. Probably the new statements around the treatment of peptic ulcer disease in our region, the Middle East, recently released, Nowadays, it's fluoroquinolones. It includes the clarithromycin, they are quite resistant. The macrolides are quite resistant. So, that's for sake of exam. This will be the slide that we should minimize. Okay. So we do it for 14 days. BID. Amoxicillin 1 gram by 2. Clarithromycin 500 milligram by 2. And one of these by 2 as well. And if there is bleeding, yani Peptic ulcer and bleeding, the BBI should be continued for 8 weeks by 2. If there is no bleeding, you stop after 2 weeks. Okay, you stop after 2 weeks. And you switch to once a day BBI for 4 weeks. Okay, it depends on. Levofloxacin-containing therapy is the first nowadays with amoxicillin. The treatment should range between 10 to 14 days. Why? 10 to 14 days, they say the eradication in 14 days reaches around 93%, 91 to 93%, and in 10 days reaches around 89 to 88 to 90%, which is comparable, which is quite comparable. So treatment at least 10 days, okay? When you go and read the literature, you find some of them they might treat for 1 week. Pediatric they tried 1 week, and it's not too bad. The eradication is around 85%, which is all of them you can compare it to 14 days. But no one has adopted in the guidelines 7 days until the moment. So all of them 10 to 14, okay? And we have, this is the triple therapy. We have the quadruple therapy. The quadruple therapy, wherever we add bismuth compound. The quadruple therapy, wherever we add bismuth compound. And these lines can be manipulated. ممكن نعدل عليهم. This is the first line. Second line, for example, if a patient has taken clarithromycin or resistant, can take metronidazole. Okay, you can switch to metronidazole flagyl as the second line, amoxicillin flagyl PDI. You can do, you can switch another for tetracycline, doxycycline. Okay, the triple add bismuth compound. So Levo, for example, nowadays some of the gastroenterologists they like the bismuth compound, levofloxacin, amoxicillin, and BBI. يعني صارت براكتس مشهورة نوعا ما. بعض منهم they like levo, amoxicillin, BBI 10 days. That's fine. It's all comparable. So if you give it 10 days, no one will blame you. If you give it 14 days, no one will blame you. So that when you go wherever the literature, a lot of things has been examined and explored. Okay, a lot of things has been examined and explored. But in the guidelines, this is the most. And still, the 2 weeks thing is still there. Okay. Next, please. Functional dyspepsia. The definition is according to the Rome criteria of functional dyspepsia. Wherever we have one or more of these symptoms, bothersome postprandial fullness, early satiety, epigastric pain, epigastric burning, and there is no evidence of structural disease in the endoscopy, and nothing to explain what's going on. This is the functional dyspepsia. From its name, there is nothing structural function. Okay. Should be fulfilled for at least for the last 3 months, at least 6 months before diagnosis. يعني آخر 3 أشهر لازم يكونوا symptoms موجودين for at least 6 months. Okay, مش نقول له 3 أشهر لا, we have to wait another 3 months. If the last 3 months and at least 6 months before the diagnosis, لازم يكون في once to fulfill this criteria. Given that we have investigated that and there is nothing structurally there. Next. Often the treatment is reassurance and dietary and psychological advice. Patients who do not respond to that would be offered a trial of acid suppressant. Next. And often, as we said in the function, you treat for 4 to 8 weeks. And as we said earlier, if there is no response, refer to the gastroenterologist. H. pylori eradication benefits only many minority, especially if you could not manage to prove that the patient has an H. pylori, he or she. The American Gastroenterology Association recommends H. pylori eradication in patients with functional dyspepsia for short term. Number needed to treat is 17, and a possible long-term. So there is no strong evidence, to be honest, in treating H. pylori and functional dyspepsia. Okay, unless we prove that. Next. Some of them, they respond to acid to BBI, and for those who did not respond for BBI, we might give some of them antidepressants like SSRIs. SSRIs has effect on the functional dyspepsia because we believe that there is a psychological background in this functional dyspepsia. Okay, like trazodone, starting low dose, amitriptyline at the time, bispheniramine, and trazodone 25. When you see functional dyspepsia is linked to the IBS as well, irritable bowel syndrome, all of these, and you can find that they have the same drugs, they share the same drugs sometimes, and those who have just abdominal colic, because IBS is classified diarrhea predominant, constipation predominant, and colic predominant. For those with colic predominant, often they will get antidepressant treatment. Next. Prokinetics can help, because this will increase the motility of the GI and will decrease the transient time, so the food is staying less in the GI tract, moving quickly. Okay, domperidone, metoclopramide. Take trial. Always we say trial because nothing has been proven to treat that. So trial. If he improves, you keep on that. If not, not. And the trial should be between 4 and 8 weeks, as we said, because these type of drugs they act centrally as well. So you have to make sure that you have to wait until the full effect of the drugs will be seen. Next. Ulcer dyspepsia, we have mentioned that referral criteria met اللي حكينا عنها العالم وهاي area. If not, treat uninvestigated dyspepsia. If yes, وقف الانستيزيس, review medication. Endoscopy finding upper GI malignancy, refer. Non-upper GI malignancy or ulcerative disease, you treat non-ulcer dyspepsia or ما يسمى بالنيات, non-erosive esophagitis, and as well non-erosive ulcer disease. إذا عندك endoscopy gastroesophageal reflux disease treated, تحكي لهم, you give them advices اللي حكينا عنها, not to drink caffeine containing drugs, not to eat, not for at least 4 hours before going to the bed. The bed should be around 35-45 degrees, 35-45. 2 pillows, if he's overweight, decrease the weight. All of these will increase the reflex, caffeine containing, and take the antacids as well. And if there is peptic ulcer disease, we have mentioned how to treat this peptic ulcer disease next. Dyspepsia not needing referral, review medication, lifestyle response. More policy type or no response for those BBI for month. That's good, you keep them under your eye. No response or relapse, just treat for the H. pylori. Relapse, low dose treatment is required. If no response, add prokinetic to drug 1 month, no response to the GI. So there is a hierarchy before you send it to the GI specialist. But all these hierarchies, why you have, and you can see it in the books, because outside they have primary, secondary, and tertiary healthcare. So, and they do not want to overwhelm the tertiary healthcare by referrals because of dyspepsia. So all these guidelines and these diagrams has been made for the GBs, because they are the first line defense in Europe and America, wherever you go, which are listed out, you will see how things go. So they will do all of these before they refer, and because the referral time, often the waiting time is months to the service. It takes might be 9 to 10 months for you to see a consultant. So you have to do something for the patient before you refer. Next. Gastric ulcers, again, you stop the anesthetics and test for H. pylori negative, PBI 1 to 2 months, endoscopy healed, low dose treatment, prophylactic not healed, refer to specialist care. H. pylori positive with anesthetic, 2 full doses, 2 months of PBI plus eradication. Okay, and you test for the eradication as we said. If it's positive, re-eradicate. If it's negative and ulcer healed, you give the prophylaxis. Ulcer not healed, H. pylori negative, refer to specialist to see what's going on, to take a biopsy from there. And then when the ulcer is not healing, you start thinking about something illegal. Why it's not healing? Okay, next. Duodenal ulcers, almost the same. stop NSAIDs, so the topographic or gastric and the duodenal, you stop the NSAID of any drugs. Test for the ulcers, treat for that for 2 months. Test eradication therapy, relapse, repeat the eradication therapy, and if it's negative, low dose treatment as well, BBI, you keep it for a while. Next. Any questions regarding the